Welcome to Health IQ. I'm Dr. Alan Siegel. Today we have a special guest, Dr. Benjamin Bonte with Bonte Medical here in Purchase, New York. Welcome, Dr. Bonte.
Hi, thanks for having me, Dr. Siegel.
Yeah. So, Doc, you're an interventional pain management specialist and a physiatrist. Tell us what interventional pain management is and what common conditions you work with your patients.
Sure, yeah. So interventional pain is the treatment of pain where we're trying to intervene on it in one way, maybe without the use of medications or trying to actually correct the underlying problem. So a lot of the treatments that we do involve trying to avoid or spare people from the use of surgery. So for example, steroid injections for knee, shoulder, hip pain, or injections in the back for problems like herniated discs or arthritis in the back.
Okay, so a lot of different conditions can cause a lot of different pain in our bodies, and pain management is something, when you mention the word pain, okay, people experience pain from head to toe, right? There's head to toe pain that can occur in our bodies, and there's always different reasons for that. So you mentioned a couple of conditions like disc herniations or arthritis in the back or in other joints. Those are common things that would cause pain in someone's body, basically, right?
Yeah, exactly. Yeah. So there are kind of two main types of pain. There's acute pain and chronic pain. And pain is a normal part of our life. It's actually evolutionary and of benefit to know when our body's injured so that we can protect ourselves from further injury. And so that's what happens in acute pain. If you injure your knee or your shoulder, your body is now signaling to yourself to protect that area and allow that to hopefully heal. Whereas chronic pain is pain that usually lasts over 6 months, where maybe the tissue injury is complete, but there's still ongoing pain.
So chronic versus acute, that's an interesting concept. So people don't necessarily know what they have unless it's of a long period of time. Is chronic pain treated differently over time than an acute person? Would you do things differently with the chronic pain patient? I know, just to get into it, neuromodulation is one thing that I believe that you work with in your practice. Explain what that is and what type of patient that would apply to. Yeah,
sure. So in treating acute pain, we have to figure out what maybe caused the injury and diagnose it, treat it. If we're dealing more with chronic pain, then we're either dealing with a condition where the tissue injury is complete, but the nerves in the area are still signaling that something's wrong inappropriately, or it's a condition that unfortunately is just kind of a one direction, like arthritis. That right now we don't have a way to reverse arthritis, so that kind of continues to kind of progress as we go on in life, and so those pain signals continue to fire as we get older, and so one of the what you mentioned, neuromodulation, is the use of electric stimulation, so to sort of interfere with that processing pathway of pain. So,
and what conditions would be appropriate for that, if not untreated, but not treated successfully otherwise?
So the some of the common conditions you might treat with that would be post-surgical pain that still presents with ongoing pain even though the surgery is complete. There's no further role for surgery. Maybe they've seen orthopedics, neurosurgery, and they said there's really nothing for them to do, but patients are still feeling pain. So that's a perfect candidate for somebody to try neuromodulation. Yeah. Okay.
And then other chronic issues, sometimes I've heard like pelvic floor issues, interstitial cystitis type of pain, other types of maybe autoimmune pain that's happening in the body that they can't figure out otherwise how to control.
Yeah. So there are conditions that cause, if it's chronic inflammatory states, so fibromyalgia, chronic pelvic pain, there are a lot of different conditions that can benefit from that. If there is an autoimmune condition, that is very important to sort of optimize the treatment of that. In pain management, we never want to be covering up pain if there's a reversible condition or something that can be otherwise mitigated and prevented from getting worse. But for conditions where either that treatment's already optimized or there really isn't, maybe there isn't a clear reason for the pain, then that's when we might consider neuromodulation.
And what about the kind of working with medication management alongside other, treatments that you might do in your office? Like I know there's a lot of, obviously we all know about the opioid crisis and what's gone on, in this country.
Yeah.
But what is the best appropriate way to use, pain medication, either steroids, NSAIDs, and/or opioids potentially, to work with patients in conjunction with some of the therapies that you do to make sure that the patient is being managed properly?
Yeah, sure. So I think about medications as part of a multidisciplinary treatment plan. So kind of taking a step back with the problem with pain is that pain is a cycle. And so if you have too much pain, it starts to affect your ability to move correctly, then it causes problems with your musculoskeletal health. It can affect your sleep, your mood, your ability to have good relationships with your support network. It can affect your employment or ability to succeed in school. And so if you're stuck in this cycle, there are many different ways or treatments that can help to try to break out of it. And so the idea is to try to minimize the pain, lower the pain, get you back into the ability to sleep well, exercise, do the healthy habits that kind of optimize your health overall. And there are many different things that can be done for that. So medications is definitely one part of it. So for example, Tylenol or over-the-counter NSAIDs, anti-inflammatories like Advil, Motrin, Aleve, those are very common and usually one of the first-line medications that a lot of people use for pain. And then there are medications like muscle relaxers or medications that treat chronic nerve pain, things like gabapentin or Lyrica. Opioids are a different class of medication that have been around for quite some time, and they're really appropriate for the treatment of severe acute pain. So things like fractures or post-surgical pain. Those are really the appropriate times to use opioids. There's less evidence for its use in chronic pain.
Long term. And I think that was some of the problems that we ran into, in the last decade or two in terms of treating chronic pain or just continuing the use of opioid medications for inappropriate cases. And I think, and then you had the addiction issues and other problems that came about that. So I think it's important what you're saying is, pain management is a multidisciplinary approach. You did mention sleep and anxiety and stress and all of those things that pain causes for people. I think that's an important part. Now, some pain can be psychosomatic and some pain, it can kind of work both ways, where your anxiety and stress and other things can exacerbate and potentially even I don't want to use the word cause pain, but surely exacerbate pain. In some cases, maybe it can cause pain, but in the reverse, if you have the pain first, it can cause all those other issues. And then being able to treat those symptoms as a holistic approach, I think it's important to getting people back on their feet and getting them back to where they are. So now I know you actually work with something called ketamine IVs. And
ketamine infusions.
I think this is an interesting concept because I think it's relatively new in terms of what's being out there. Maybe not, correct me if I'm wrong, but it's being used for chronic pain. People also have maybe depression, post-traumatic stress disorders, anxiety, maybe related to the pain and other issues. So talk about that, because I think that's an interesting concept.
Yeah, so ketamine is, there's quite a bit of evidence evolving for its use in the treatment of both mental health disorders like depression, anxiety, PTSD, and also for the treatment of chronic pain. And so as a chronic pain specialist, my focus is obviously treating pain. But these conditions are not independent and in silos. You're totally right, because patients who are in pain, they start to develop depression or anxiety, fear of movement, kinesiophobia. And that can really be a barrier to the rehab process. And then people who have a history of depression or anxiety that maybe going into before developing pain, that can amplify the way people feel pain. These are connected things. I always give an example of like an amoeba that is injured by something. It starts to exhibit avoidant behavior to the thing that injured it. So this is also evolutionary to have anxiety. But then when it becomes out of control and it affects your ability to rehabilitate from the injury, that's the problem. So ketamine.
How often would a treatment like that be administered to someone, and how often would that type of treatment be done on the appropriate patient?
Yeah, so the typical sort of treatment for a ketamine infusion for chronic pain is a series of around 6 infusions done over a 2 to 4 week period initially, and then after that. Sometimes people don't need another one for a very long time. It really depends on the patient. Other people might benefit from what I would describe as a booster every, somewhere between 1 to 6 months, depending on the person.
Okay.
Yeah.
And are there other medications necessary in between that, or generally speaking, that medication works on its own, or you try and see how it's functioning on its own?
Yeah, I mean, I usually would use ketamine as a more, if other treatments have failed. Right. Ketamine is still, while there is evidence for it, it's still technically off-label use. Okay. Since it's not covered by insurance, that we typically would try the things that have the strongest level of evidence that most insurance companies would cover, things like the injections or medications first, and then if that doesn't work for patients, then ketamine might be an option.
Okay, interesting.
Yeah.
Now, some of the more common things, obviously, we spoke about neck and back pain. Like we know, traumatic injuries, chronic injuries, overuse injuries to our spine. Our spine seems to be, one of the weaker points in our body, unfortunately, where we have a lot of chronic issues. Myself as a chiropractor and our business being in physical therapy, we see obviously a lot of spine and back rehabilitation. How much is, sort of like traumatic or injury or arthritic, and then how much is it, do you think, is starting to be affected by our lifestyle, our sedentary lifestyles, our postural lifestyles, the way that we're sitting, the way that we're working, the way that we're by computers all day? Do you feel like it's all kind of combining into like a problem for our spines?
Yeah, no, I mean, I definitely think there's the expression, the sitting is the new smoking. Yeah, I think that I think you're always going to have the patients who are have had these injuries, whether they're kind of the weekend warriors who are doing a fitness class on the weekend, or maybe somebody who just has like kind of a repetitive stress injury, cumulative trauma disorder from like a job that just involves a lot of heavy lifting. But I think like as our jobs start to move, just like our economy moves into more kind of like desk work, computer work, and working from home, that really has kind of really revealed a lot of problems. It hasn't really helped. Yes. Yeah. So people, especially like at the beginning of the pandemic, it was very difficult for a lot of patients to have kind of a good work from home setup. So people were working on a laptop, with the screen pointed this way and just looking straight down for hours and for months. Trying to figure it out.
Chronic, disservice to our body, basically, just continually doing the wrong things and sitting with the wrong posture. And but in terms of like disc herniations are common things people hear about. Stenosis is another word people hear a lot about. What are the treatment protocols for those types of things? Like a lot of times, they'll see, there's surgery, discectomy, fusions, other things that can be done, stenosis a little bit more complex at times, depending on where the stenosis is occurring. And just to clarify, stenosis is a narrowing of a canal in the spinal cord or column, or where the nerves may exit. Sometimes a little more difficult to treat. But what would be like some procedures you would do for those things? Yeah.
So you definitely want to take a look at their imaging to get a sense of what the underlying anatomy is, because disc herniations can be small or they can be massive, and most of the time it falls somewhere in between. And so if the patient has disc herniation that, where it's safe to perform a minimally invasive procedure, we do what's epidural steroid injections for disc pain is a very common treatment. We use an X-ray machine to guide a needle in between the lamina, so the area in the spine, through a ligament into the epidural space, where we're dropping the steroid, just injecting the steroid into the area and then removing the needle. So that can be done very safely in an outpatient setting without the need for any sort of sedation. And of course, you're using local anesthetic, lidocaine, to make sure that patients are comfortable, and that really doesn't create any sort of scar tissue. It seems
like there's been a little bit of a shift in like the use of anesthesia during these procedures versus removing the anesthesia component from that. It seems like, maybe even 5-10 years ago it was more common to have someone sedated or under anesthesia. But if people are generally calm, maybe a light sedative, whatever, a Valium or something, to calm them down for the procedure, but they don't need the intravenous sedation as much as maybe they had taught years ago.
Yeah. I mean, it's not as common. Some patients, of course, will need it. Patients with severe needle phobia. But I would say the vast majority of patients don't need anything at all. But again, like a Xanax or something for the patients who are having difficulty with the procedure. But it's also a matter of safety. If we're in around important structures that we want patients to be able to tell us if there's something unusual. Right. Whereas if they're not able to communicate that, then that increases the risk of injury. So we typically don't use sedation for those procedures.
And what other types, like facet blocks or other types of, that's a little bit different type of, if you do nerve ablations, things of that nature, what would be the difference in those conditions and or treatments versus like an epidural?
Right. So epidural and disc pain usually is pain that might be worse with kind of flexing forward, things that load the discs, or prolonged sitting, coughing, sneezing, or it might cause pain that travels towards the arm or the leg, and then that's usually treated with an epidural. Whereas pain that is related to the joints, the facet joints in the back of the spine. First, the character of the pain is a little bit different. It might be more like stiffness, tightness, achiness.
More local pain.
More local. Okay. It kind of classically would not travel down the arm or the leg, and usually is worse with kind of things that put more pressure on those joints. So extending backwards or extending up, looking up. So the treatment that you're talking about, facet blocks and radiofrequency ablation, your facet blocks are diagnostic test injections where you're putting lidocaine on the joints to see if it's actually the source of the pain. So it's not expected to really produce long-term relief, but if you can identify that that's the source of the pain, then you can feel more confident proceeding to the radiofrequency ablation. So the radiofrequency ablation, you're using specialized needles that have tips that use thermal heat to basically burn or deactivate the sensory nerves that go to these joints, and that provides pain relief, but also it stops that inhibitory process where the pain sends signals up to your brain that then sends signals back down to your neck or your back that tells everything to tighten up. So it can actually improve range of motion. It can improve your ability to move or do therapy. So it's more than just pain relief or decreasing the number. It kind of improves function as well.
So this multifaceted approach to pain and based on the conditions, you seem to have a lot of different tools in the toolbox, so to speak, to go after someone's condition and or their pain. I think what's interesting nowadays is the move towards like what they call regenerative medicine, or using PRP and stem cells and some other they call it like gel shots of the knees, things like that.
Yes.
Tell us about like PRP in your practice. What types of conditions might be appropriate for that? Where's the clinical proof, in terms of like, which conditions seem to be responding best to that condition?
Sure, yeah. So PRP is platelet-rich plasma. So plasma is a component of our blood that we can actually isolate by drawing it from the patient, spinning it in a centrifuge, and then isolating the component that contains the yellow plasma with the platelets. And platelets have a bunch of growth factors that help promote a natural healing process to damaged tissue. So in that way, you're actually not just decreasing inflammation, as is with the case with steroids. You're actually promoting a healing process that actually does create some inflammation. So there is a pro-inflammatory period after PRP injection, but the long-term effects of it are that it actually can promote collagen remodeling.
The healing effect. So what types of conditions would you say, like Achilles tendonitis or Achilles tears, maybe like tennis elbow, is it those types of things, or is it chronic strains or sprains of like muscle tissue or tendons and things of that nature?
Yeah, there is good evidence for PRP in conditions involving arthritis of the joints of, say, the knee and the shoulder and the hip, chronic tendonitis, tennis elbow, golfer's elbow, tendonitis in the rotator cuff. Those are all really kind of treated successfully with PRP. And there's actually some evidence for PRP in the epidural space. So patients who have maybe tried a steroid injection, epidural, and that hasn't worked, you can actually do epidural PRP injections that can help promote healing to things like tears of the discs themselves. But there is variability in terms of the evidence. So some tendinopathies don't have as good response. Patellar tendon and Achilles tendon, it's a little bit more mixed.
So this is a procedure that can be done like interarticular into an actual joint space, as well as, or in and around the tendons and the ligaments of the joint?
Yes.
It could be both? Okay.
Yes. And you mentioned
also under fluoroscopy, or it depends on where you're trying to get.
It depends on where you're doing it. Like an injection around the rotator cuff, ultrasound is really the best, and you can do it really depends. If you wanted to do, of course, an epidural would be a fluoroscopy, and then other locations can be really either or. Yeah.
Yeah. Okay. Yeah. All right. Yeah. And then last subject I want to touch on, sort of like out there, but I don't think anyone really knows what it is stem cell.
Oh, right, yes.
Because you read a little bit about it and you hear about it, and people explain it to you, but like what is it? How is it being used? How safe is it? And then where are these stems coming from, and like what are we trying to do, like in terms of like regenerative medicine, like to help with osteoarthritis and other pain issues, like what's been the science on that so far?
Yeah, no, that's a great question. So there, when we talk about stem cells, most of the time in this setting, we're talking about stem cells that have already differentiated to some degree. So we're talking about stem cells that are now mesenchymal stem cells, if you're getting it from the bone marrow, where they might be able to become cartilage tissue or help with tendon healing. But we're not talking about a stem cell that can become like a heart cell or a brain cell. So these stem cell therapy is typically you can take bone marrow, aspirate, and then So
you are taking it from the patient again,
yes.
Similar like PRP. You're taking it, so it's kind of holistic from their own body.
Yes.
I believe there's been some product and some controversy of like stuff that's outside of the body, right?
Right.
And there's been some not issues with that, but just knowing where the source is, where the products are coming from.
Right. There's there's regulatory
autograft, allograft.
Right. So you essentially we are able to use treatments of stem cells when it comes from the patient's bodies, and then there is still ongoing investigation regarding the safety of products that are from other sources. There's some investigation into products that are not derived from patients, because if you think about stem cells of a 20-year-old versus an 80-year-old, the health of them stem cells themselves are different, and when we inject stem cells, we won't know the quantity we're injecting. So there is a lot of interest in trying to identify products where the amount is predictable. You spare the patient the process of actually kind of drilling into bone marrow, which isn't pleasant. And so there are some newer products like secretomes or exosomes, which are being currently investigated for things like osteoarthritis and as an alternative to autologously derived stem cells. Yeah, and yeah, there is some really good evidence for these treatments for things like knee osteoarthritis. Right. Yeah.
And then the last thing we didn't really touch on, as a kind of a multifaceted, holistic pain management doctor, so to speak, lifestyle, nutrition, diet, keeping healthy weights on patients. All of these things surely factor in. I know it's a society, we don't always eat the best foods, high in sugar, high in, caffeine. Right. There's a lot of things that, in my mind, surely can help in surely keeping weight off, keeping core strength, exercise. People that have, more weight on their body are surely going to have a higher load on their spine, on their knees, on their hips, on weight-bearing joints. The body has to be supported by something, and it's your joints and your musculoskeletal system, right? So we're putting undue stress. So do you discuss these things with your patients? I know sometimes they just want to get out of pain, and pain is their priority. But long-term, short-term, how to live a healthier life.
Yeah, I mean, patients are coming in, they're seeing me. I'm seeing them for a very small fraction of the day, and then the other 23 plus hours outside of my office, they have a lot of homework to do, right? So my goal is to, if people have an injury, my goal is to put out that fire, and then when they leave my office, the idea is to have them rebuild the house. So they have to do the stuff you're mentioning. So a physical therapy program that focuses on rebuilding and re-strengthening the area that was injured. Modalities to help relieve and decrease pain and improve function. Things like massage, chiropractics, acupuncture can all be really useful. And then we also want to think about nutrition, diet, and stress management and sleep. And it can be really overwhelming when you're in pain because pain can affect all of those things, and it just throws people off of their routine. So I try to tell people, it's overwhelming to try to do everything at once. Just try to come up with a small, measurable change. Go do your therapy exercises 3 times a week or 4 times a week. Start with that, and then focus on your next thing you want to add. Just because try to not overwhelm people and give people the sense that they can do this.
100%. I couldn't agree with you more because we find you have to give patients little baby steps and then just say, hey, we're going to make change over time. This is a partnership. This is a sort of like an agreement between us that we want to get you better. You're going to get better. But help us help you, and these are some of the small steps that we need to do. And having a team management approach, like you said, you can't do everything in your office. You're focused on these procedures that can help people with immediate help, which is great. But there are structural issues, there are conditional issues, there are other things that need to be addressed. So this chronic cycle hopefully doesn't happen, and they can kind of get out of pain and stay out of pain and live a healthy, wealthy life. So I think that's important. But I think the work you're doing is great. I want to thank you very much for being on the show, and I think it's informative for our clients. Is there anything else that you want to discuss or go through that we didn't touch on?
No.
We hit on everything you're doing?
Yeah, Dr. Siegel, thanks for having me. This is great. And anyone who's interested in learning about some of the treatments that we're talking about or my practice, they can go to bontemedical.com and learn a little bit more.
Excellent. I would highly recommend that they do that. So thank you very much. All right. I'm going to say goodbye for now. Thank you for watching Health IQ. I'm Dr. Siegel. We'll see you next time. Bye-bye.